This is why it's impossible to answer the question, what peptide should I take? Two patients can look almost identical online and need completely different strategies. People ask this every day. What peptide should I take for weight loss? What peptide should I take for fatigue? What peptide should I take for PCOS? What peptide should I take for inflammation? What peptide should I take for hormones? And I understand why people ask it. They're frustrated. They have symptoms. They have been dismissed. They have tried diets, tried supplements, have researched online extensively, and now they want a direct answer. But here's the problem. Medicine doesn't work that way. At least good medicine shouldn't work that way, because the same symptom does not always mean the same biology. Two patients can have almost identical symptoms and need completely different treatment strategies. So let me show you what I mean. Let's compare two female patients. Same age range, same general complaints, same social media questions, but very different patterns. Patient 1 is 32 years old. She says, I have PCOS. She has irregular cycles, acne, hair shedding, weight gain around the abdomen, fatigue, brain fog, inflammation, poor recovery, food cravings, sleep disruptions, anxiety before her period. And she says, what peptide should I take for PCOS? Now, patient number 2 is also 32. She has irregular periods, irregular cycles, acne, hair shedding, weight gain around the abdomen, fatigue, brain fog, food cravings, poor recovery, and trouble losing weight. She has the exact same question. What peptide should I take for PCOS? Online, these two women look almost the same, but through the Praxis lens, they're not the same patient, and they should not be treated like the same patient. This is where standard medicine can become limited. Standard medicine is very good at naming categories. PCOS, hypothyroidism, insulin resistance, autoimmune disease, depression, obesity, anxiety. That matters. Diagnosis does matter. But diagnosis is not the same as understanding the person. A diagnosis names the category. The Praxis lens asks, what is the pattern? What is the signal? What is the system? What feedback loop is keeping this patient stuck? So let's go back to patient 1. She carries a diagnosis of PCOS. And when you look deeper, her story changes. She develops symptoms after a major immune stressor, maybe a viral illness, maybe postpartum immune shift, maybe chronic inflammatory exposure. Maybe she has a mold history. Maybe a long period of gut inflammation. Maybe recurrent infections. Maybe autoimmune family history. Her labs show elevated TPO antibodies, positive ANA, elevated immune-inflammatory markers, low vitamin D, possible iron dysregulation, and maybe gut symptoms. Bloating, loose stools, constipation, food sensitivity patterns, histamine type patterns, joint pain, skin flares, morning stiffness, poor recovery, and her androgens may be elevated, but not dramatically. Her insulin might be mildly abnormal, but not enough to explain the entire clinical picture. So yes, she may meet the criteria for PCOS, but PCOS may not be the root pattern. PCOS may be the downstream expression of an immune-inflammatory loop. That is a completely different patient. And this patient, the question isn't simply how do we lower androgens? The better question is, why is the immune system inflamed, reactive, and dysregulated? Why is the gut immune axis irritated? Why is the hypothalamic pituitary ovarian axis being disrupted by inflammatory noise? Why is the body signaling stress, inflammation, and hormonal dysfunction all at the same time. This is where Praxis model becomes different. The pattern isn't just PCOS. The pattern is immune dysregulation with PCOS-like expression. The signal we might need isn't simply metabolic weight loss. The signal may need to be immune regulation. This is where peptide like thymosin alpha-1 may belong in the conversation. Not because TA1 is a PCOS peptide. It's not. Not because TA1 treats PCOS. That's too simplistic. TA1 belongs in a discussion because it's an immune modulating peptide. It is discussed around T cell coordination, dendritic cell behavior, innate and adaptive immune function, and immune balance. So, for patient 1, the strategy may look like this. First, confirm the diagnosis. Don't assume every irregular cycle is PCOS. Evaluate the thyroid, prolactin, pregnancy if it's appropriate, androgen levels, DHEA sulfate, 17-hydroxyprogesterone if it's indicated in this patient, fasting insulin, glucose, A1C and home IR, lipids, liver enzymes, inflammatory markers, iron, B12, vitamin D, autoimmune markers when the history supports it. Then we'll ask, is this primarily metabolic PCOS or is it immune-inflammatory PCOS expression? For patient 1, the treatment strategy is not just lose weight and take a metabolic peptide. It may be calm immune activation, address gut barrier and dysbiosis, correct nutrient bottlenecks, improve sleep and circadian rhythm, reduce inflammatory triggers, assess thyroid autoimmunity, support protein intake and muscle preservation. Then, under clinician guidance, consider whether an immune regulating peptide like signal like TA1 belongs. The goal isn't to boost her immunity. That phrase is sloppy. The goal is immune coordination, better immune tolerance, less inflammatory noise, better recognition, better regulation. And if the immune loop improves, the hormone loop may become easier to regulate. That's patient 1. Now let's look at patient 2. Same symptoms, irregular cycles, acne, hair shedding, abnormal abdominal weight gain, fatigue, brain fog, cravings, poor recovery, difficulty losing weight. But her pattern is different. Her history is not primarily autoimmune. No major inflammatory story. No autoimmune markers. No gut immune red flags. No major joint pains. No clear immune flares. Instead, her pattern is metabolic. Her fasting insulin is high. Her HOMA IR is elevated. Triglycerides are high. HDL is low. Waist circumference is increasing. She has strong food noise. She is tired after meals. She craves carbs. She has fatty liver markers. She has central adiposity. Her testosterone is elevated. Her sex hormone binding globulin is low. And her cycle disruption tracks with weight gain and insulin resistance. This is a very different feedback loop. In this patient, insulin may be one of the dominant drivers. Insulin does not only affect blood sugar. Insulin talks to the ovaries. Insulin can worsen androgen signaling. Insulin resistance can lower sex hormone binding globulin, increasing free androgen activity. Higher androgens can worsen acne, hair changes, cycle disruption, and metabolic dysfunction. Then, weight gain worsens insulin resistance. Insulin resistance worsens androgen expression. Androgen expression worsens symptoms. Symptoms worsen stress. Stress then worsens sleep. Poor sleep worsens insulin resistance. That is the loop. This isn't primarily an immune pattern. This is a metabolic androgen feedback loop. So, in patient 2 asks, what peptide should I take for PCOS? The answer isn't TA1. The answer is we need to address the metabolic signal. This is where GLP-1 based or incretin-based therapies may belong in the conversation. Not because they are weight loss shortcuts. That's very shallow framing. But because GLP-1 signaling can affect appetite regulation, food noise, gastric emptying, insulin response, glucagon signaling, weight loss, and metabolic control. In PCOS patients with obesity or insulin resistance, that can definitely matter. So, patient 2 strategies can look like this: protein target, resistance training, fiber, sleep, electrolytes and hydration, muscle preservation, cycle tracking, metabolic labs, home IR, lipids, liver markers, androgen, and an androgen panel. Then, if it's appropriate, discussing a GLP-1 or incretin peptide strategy. The goal isn't just to lose weight. The goal is to lower the metabolic pressure driving the reproductive hormone loop. If insulin improves, androgens may improve. If androgens improve, cycles may improve. If weight decreases while muscles protected, metabolic flexibility may improve. If food noise decreases, adherence may improve. If adherence improves, the system may start responding. This isn't peptide hype. This is feedback loop medicine. Now, compare the two patients. Same symptoms, different dominant loops. Patient 1, PCOS label, but immune-inflammatory pattern. Gut immune activation, autoimmune clues, inflammatory symptoms, possible thyroid autoimmunity, poor recovery, systemic reactivity. Potential peptide strategy is TA1 as an immune regulation conversation. Maybe KPV or gut barrier strategy, depending on her symptoms. But the primary question is immune coordination. Patient 2, PCOS label, but metabolic insulin pattern. High fasting insulin, high HOMA-IR, food noise, central adiposity, low sex hormone binding globulin, elevated androgens, fatty liver patterns. Potential peptide strategy would be GLP-1 or incretin-based therapies as a metabolic signal, but only with muscle protection, protein, training, and monitoring. These patients look almost identical online, but they're not the same biology. And this is why protocol medicine fails. A protocol sees the label. Praxis sees the loop. A protocol says PCOS equals this. Praxis asks, what is driving the PCOS expression in this human being? A protocol says, here's the peptide. Praxis asks, what signal belongs in this system? A protocol says, try this stack. Praxis asks, what are we monitoring? And what would make us stop? This is individualized care. Now, let's be clear. Standard Western medicine does have strengths. Emergency medicine, surgery, imaging, pharmaceutical precision, endocrinology, cancer care, infectious disease, critical care, and there's several others. These are very powerful. The problem isn't that standard medicine is useless. The problem is that standard medicine often becomes too label-centered in chronic complex conditions. It names a diagnosis. It gives the first-line treatment. It checks the box. But many patients are still asking, why did this happen? Why does my body keep returning to the same pattern? Why do I still feel terrible? Why did this same treatment work for somebody else, but it didn't work for me? This is where the Praxis lens belongs. Pattern, signal, system, evidence, risk, monitoring, and decision. Because peptide medicine isn't about memorizing names. It's not about random protocols. It's not about online comments telling strangers what to inject. It's about understanding the human being. So when someone asks, what peptide should I take? The better answer is, show me the pattern, show me the labs, show me the timeline, show me the triggers, show me the system, show me what changed, show me what has been ruled out, show me what you are trying to measure. Because without the pattern, the peptide is just a guess. And a guess with a protocol is still a guess. This is why Praxis Peptide Institute exists, to teach patients and clinicians how to stop asking shallow peptide questions and start thinking through biology. Same symptoms, different patients, different loops, different signals, different strategies. That is medicine.